This next video discussion in the clinical toxicology series is about the use of vitamin K, corresponding to the Antidotes in Depth chapter A18 in Goldfrank's Toxicologic Emergencies. I know I've said it before, but I think this is going to be a short one. The learning objectives are that once you've studied the related course materials, you'll be able to explain the mechanism how vitamin K reverses toxicity from warfarin and other similar oral anticoagulants, and to be able to outline a dosing regimen for antidotal vitamin K. As we know, warfarin competes with and interrupts normal vitamin K metabolism, so it makes sense that vitamin K can be used to reverse over-anticoagulation caused by warfarin. There are other similar therapeutic oral anticoagulants available around the world, but warfarin is used almost exclusively in the US. And there are also various long-acting, orally active anticoagulants used as rodenticides, such as brodifacoum, that rely on the same mechanism and can therefore be treated with vitamin K. Warfarin works by blocking the regeneration of vitamin K needed to synthesize multiple clotting factors. So the vitamin K gets used in one round of the cycle depicted here, and then it's stuck in its inactive oxidized form. It can't be reduced back to the active reduced form, so you get a functional vitamin K deficiency. There are two main scenarios for considering vitamin K reversal of warfarin over anticoagulation. Either the patient is bleeding and we're concerned about it, or they're not bleeding, but the INR is uncomfortably high and we're concerned about the risk for bleeding. If the INR is too high in a stable non-bleeding patient, this is going to correct over many hours to a few days, even if we do nothing more than withholding the next dose or two of warfarin. If the INR is over 10, then the patient is given oral vitamin K 1 to 2.5 milligrams. If faster resolution is desired, the oral vitamin K dose can be up to 5 milligrams, and you check the INR in approximately 24 hours to see if additional low doses might be needed. For patients with serious bleeding at any INR level, or for those with life-threatening bleeds, there's obviously more urgency. You do give vitamin K, but that's almost a secondary treatment at this point. These patients are treated with 4-factor prothrombin complex concentrate to immediately restore functional levels of multiple clotting factors. And they're also given vitamin K, 5 to 10 milligrams by slow IV infusion. Additional vitamin K dosing may be needed every 12 hours. And here's some additional vitamin K dosing considerations. Because of how it works, we don't expect immediate results from vitamin K. The body uses it to synthesize new active clotting factors, and that takes time, several hours at least, to reverse over anticoagulation. So again, if you need faster effect in a patient with bleeding complications, you'll have to also use PCC. And if you're giving vitamin K intravenously, it's given slowly, up to 1 milligram per minute, to avoid serious anaphylactoid reactions. These reactions can occur but are rare, reported in about 3 of 10,000 doses. And up to this point, we've basically just been considering therapeutic misadventures with warfarin. In an intentional acute warfarin overdose, significantly higher vitamin K doses may be needed. With coagulopathy from long-acting anticoagulant rodenticides, the vitamin K dosing may need to be high, up to a couple hundred milligrams daily in some reports, and prolonged. Okay, that's it for vitamin K. I'll be seeing you around.